David oftentimes will do a lot of non-NKT assessments like range of motion or different orthopedic assessments. How much of that do you do with your testing? Are there any standard protocols of that kind of testing that you do as well
Yeah,
to kind of guide your NKT?
I do a lot of orthopedic testing and neuro evaluation and all those kind of standard evaluative techniques that, we're trained to do and told we should be doing. Where I fit it in is a little bit case by case, but at some point everyone's gonna get it. So usually there's a visual assessment, there's a palpatory assessment, and in the palpation class I called it the primary palpatory assessment, where it's just kind of like a head to toe quick palpation. Takes about a minute. Just pretty much palpate everything in about a minute, get your quick impression of everything that's going on. I start kind of rating and ranking different things based on how problematic they felt based on palpation. And then I'm going to evaluate their trouble area, whatever area, not only whatever area their symptom related to their symptoms. So they said my shoulder hurts. Yeah, I'm absolutely going to examine the shoulder, but also examining areas that popped up as relevant with my visual and palpatory assessment. So they might say, ow, my shoulder. Well, what I'm seeing is, ow, the right hip. Something's up with that right hip. Like the psoas felt like a nightmare. The QL was like just wrought iron. And, I could see the Trendelenburg gait, and you're cheating with your QL and all these other things. So I'm always kind of simultaneously looking at the area of their complaint, but also the area that seemed to be of greatest significance to their body on the whole. And oftentimes they're actually related. So I'll examine those two areas with much greater specificity. So then I'll be doing like motion palpation and more local neuro and physical exams of those areas, different orthopedic tests, etc. And then I start kind of piecing together my picture of what I think is going on.
Okay. Could you run me through kind of the timeline of, what's like the outline of a typical session with you? They come in, you talk to them, you take some notes, you do orthopedic assessments, you do NKT, you do correctives. I mean, what's kind of the flow of like a session?
As a general rule, it's a little different if it's a first timer or a follow-up.
Okay. Could you give me both?
Okay. So if it's a first timer, hey, how you doing? And let's get you checked in. So I don't want to hear their information yet. I just want to get them checked in. So I use an electronic health record that's iPad based, and I have all my custom forms on there and clinical note templates that I use on there. So I'll get them all checked in and have them sign all the release forms, get their medical histories, any other information that I don't want to forget about them, even if it's just personal information. So I remember, their wife's name, or I remember what they do for a living. So even things that aren't especially clinically relevant, but I just want to remember them about that person, I'll take all those notes. That whole process usually takes about 12 to 15 minutes on a first timer. And then I begin with the exam. So usually at that point, I've already observed their movement by watching them walk in the door, and they don't know it, but the whole time I'm talking and getting the history from them, I'm doing a visual evaluation on them to see how they move and see how they walk, how they bend, etc. So I already have a good picture of that in the general sense before we even begin the session. Then I'll have them get on the table, and then I'll do my primary palpatory evaluation, just to kind of get a quick head to toe. And then I start that survey testing where I test a little bit of everything to get a sense of what's going on, if I can spot any bigger patterns. And then I start doing more detailed examination of the areas that popped up in my other evaluations. So whether it be palpation or movement or the area of their complaint, I'm going to do more detailed information or information gathering. And as a general rule, I'll start on whatever their complaint is. So if they say their shoulder hurts, even if I don't think their shoulder is the main driving force behind the shoulder pain, I'm going to work on their shoulder first, because I want to get a certain amount of relief immediately. Because what that gives you is buy-in. And they'll trust me to do whatever long game planning and indirect body work I want if I get that get them that initial bit of results and say, okay, you could get it here. Now you can get it here. Cool. I'll work with you. Do what you got to do. So they can see I have that in my ability to get them quick outcomes. Now they'll trust me to play the long game and say, we really need to work on this hip. Otherwise, anything I do to that shoulder is not going to hold. But now I have their trust. So I always want to get an initial bit of relief, however I have to do that first. And then I can do whatever my judgment tells me I need to do. But as a general rule, I'll always start locally on their area of complaint and then kind of work my way out from there.
Yeah. Build a little bit of trust and rapport with them.
Very much. And as techniques go, NKT isn't too out there. Most people can somewhat follow along with it, even if muscle testing is new to them. They can see, he did a release in there. People like releases. That's very linear to them. That makes a lot of intrinsic sense. They can see, it was weak, now it's strong, or I couldn't bend, now I can. Cool. So that's all very experiential. They can get on board with that. But sometimes it's a little strange and unfamiliar. And if you're doing strange and unfamiliar things with people and you aren't fortunate enough to get immediate results, you might have trouble getting them to come back. Because if you do something that makes sense to them and they don't get results, they give you a couple tries. People don't go to physical therapy and get a walk-off home run the first visit every time, nor do they expect it. But somehow they can often expect it, or they aren't giving you that latitude if you're doing something they don't understand. It doesn't make any kind of intuitive sense, because then it's really easy to dismiss it as quackery. So no, it's not that I don't feel better because he still has more to do. I don't feel better because it doesn't work, because that's weird stuff and I don't want anything to do with that. Right. I think I'm going to go another way with this. Yeah. So, and I don't care who you are, no one's impervious to that kind of outcome. So I like to do the most straightforward whatever I can initially to get them some gains. So if I can do fancy stuff and get them some gains right away, great. If I have to just do some release work to get them some gains right away, then that's what I do. Whatever it takes to get that buy-in, to get that trust, then I can just follow clinical judgment for the rest of the journey. Yeah.
Thomas, would you be willing to share any failed outcomes maybe with us?
Yeah, my very first session ever.
Okay.
My very first session, this is when I made the transition from massage to what I would call body work, or from massage to what we now call NKT. And it was a client who I had already, so he got to experience both. And he came to me with a bunch of shoulder pain and problems. We all know the client type, kind of a older guy, used to be a high level athlete, and in his head he still is, but physically he isn't. So they're out there doing, like, using work exercises and workout methods that are about 50 years outdated. They're wearing the too short shorts and the knee-high socks in the gym. Still doing what their high school football coach showed them in the 60s. So that was that guy. And so I go to test his shoulder, and I just ran every shoulder test I knew. At that point, I'm like, cool, I'm an encyclopedia of muscle testing. I know all these muscle tests, and I'm gonna figure this out. Let's go. And I get in there and I start testing his shoulder, and I literally could find nothing. Every single test was strong, and I basically blanked on protocol. There was that concept of relational inhibition, relational compensation, testing things against each other. Totally spaced it. I just tested everything in the clear and just whispered to myself, shit. And then just went back to doing massage. Because at that point, that was my only plan B. And then I saw him again and was a little more mentally prepared and found some good patterns when I was able to get him some improvement. As it happens, he ended up having like multiple tears and torn bursa and shredded this and ripped that. So he needed surgery. I wasn't going to hit a home run on that one, no matter what I did. but I was at least able to give him some relief.
Mm-hmm.
But that first session was an epic fail.
Wow.
Got absolutely nowhere with him. I had a case, this actually motivated me to ask David one of those questions I mentioned to you about how much is enough and how much is too much.
Mm-hmm.
This lady came in for a neck issue that she had had for 20 years, and she had a lot of history from car accidents and whiplashes and everything. And I felt really solid about my neck work, and I did about 45 minutes on her neck, and she left feeling like $1 million. Got a call the next day that she could barely get out of bed.
Wow.
And just she felt like she had been hit by a train.
Wow.
And she was basically looking to me for help. She wasn't even mad. She was like at a loss for why she felt this bad. And all I could think of was that I must have done too much. Because I still, even in retrospect, felt that the work I had done was good. Like, I found good patterns. I had used good technique. I hadn't tested too hard. I gave her correctives. And like, I felt that I had used sound technique and sound judgment in how I actually did the work. So I could only think it was a matter of quantity. So I was able to get her to kind of get on board with that idea. I think what we did was good. I think I just straight up did too much. Why don't you come back in for a free session? And I'm literally just going to do like 5 minutes just to calm it down for you. And so she came in, she was willing to give me another shot. And I literally just did 5 minutes on her neck, much of which was stuff that I had done on her in the previous session. But of course it didn't hold because I totally blew her out. So I just did 5 minutes. She left feeling pretty good. And then I get a call the next day and I'm like, oh no, I see her number on caller ID. And she's telling me how this is the best she's felt in 20 years.
Wow.
So I just took exactly what I had done the previous time and just did about 20% of that.
Okay.
And then it was great. And I've since had other slightly less dramatic experiences that let me know when it comes to necks, aim low. When it comes to chronic neck problems, I always do less than I think I can get away with.
Okay.
And that's always worked out best for me. Same with jaw, same with pelvic floor, any of these really high level chronic problem areas. I tend to just be very conservative about the quantity of work that I do.
Okay.
Obviously, my quality has evolved over time and the techniques I use have evolved over time, but I still have never forgotten those hard lessons, harder for them than me. And,
right.
To be conservative. And I highly recommend learning from my mistakes.
Yeah, thank you. When you see people with, like you said in your example there, the lady had 20 years of neck issues. Do you see that is also another thing that might make you do less work when they have a longer issue, a more chronic issue like that? Or does that really make a difference?
It's not, well, it definitely makes a difference, but it's not purely a chronological factor. That's part of it. There's a tendency that when something has been around a while, the problems get more complicated. So because compensations start creating their own compensations, and next thing you know, symptoms become their own problems. And then their symptoms become their own problems with their own symptoms. And everything starts branching off and getting more complicated. Like the dysfunction is setting up franchises all over the body. And it's no longer a matter of where you can just treat the original problem and everything goes away. After 20 years, that's generally not the case anymore. Those problems created their own problems, which still need your attention. Maybe you can clear a bunch of them by going after a hierarchy, but there's often more than one problem now. So you have to be mindful of that. But also people who have been in chronic pain, there tends to be a huge limbic component to that. They tend not ambivalent about the fact that they've been in chronic pain for 20 years. They care. It matters to them. They have feelings about that. And those feelings can very much get in your way and their way of you treating that problem. So I have other methods that I do in dealing with limbic problems that I definitely have to factor in when dealing with chronic pain in particular.
Okay. And then back to the first example of that first guy that you worked with where you just forgot the protocol and was just firing away with all kinds of different tests on his shoulders. Have you since learned any good methods of clearing confusion when you get lost with somebody, when you're in that space, you're like, I don't know where to go next with somebody? Is there something you kind of revert to help clear your head?
Yeah, I have my patented move where I
Yeah.
just grab their limb and I jiggle it while I think. It's like the old massage move. I just grab the leg and I just start kind of oscillating it,
Yeah.
nice and loose. And
Uh,
at this point, I don't have to spend a great deal of time these days in sessions kind of
mm-hmm.
figuring out what to do. I've been at it long enough that I can just kind of move through it, but I still tend to do that as a matter of habit. Like if I'm between moves and I'm kind of prioritizing in my head where I want to go next, I'll sit there and just kind of oscillate the limb. And so it feels like I'm doing something. You know, I'm maintaining that contact with the person, so it keeps them nice and relaxed, and I'm engaged, but I'm not actually doing anything.
Mm-hmm.
So that tends to be my time filler. Like in the commercials, all of a sudden I just cram a Snickers into my mouth while I'm trying to figure out what I'm going to do next.
Yeah.
That's my Snickers technique right there.
Yeah.
Is I just start oscillating the limb while I figure out what to do.
Mm-hmm. Are there any really common cues that you've learned? I heard you say, I'm going to position your leg right here and resist against me. David explained some cues. Are there any really specific cues that you've kind of learned and
Cues for the muscle testing?
Yeah, muscle testing, or just ways to help people understand. You said that you don't, you try to explain less, but just any phraseology you use that helps people to understand. Because sometimes when people are talking about NKT to their clients, they just don't know how to explain it well. Is there good phrases or cues that you use that you've learned?
Well, this is a slight I'll answer that in just a moment. There's
Okay.
a slight tangent here, but I think it's worth mentioning. When I had my very first class with David, again, he was teaching the previous incarnation of this work at the time. And the very first conversation we had in class before we learned any techniques and after we had kind of just introduced ourselves is we had to come up with our 30-second elevator speech of explaining what the hell we're doing. What is NKT at the time, NMR? What is it, and how do you explain it to someone in 30 seconds or less? And he basically gave us his canned elevator speech. And I think it's important that people have prepared answers to things like that you have prepared explanations, that you're not trying to wing it in the moment, because then you might say it inartfully or inaccurately or just be totally stumped, and none of that is going to help build rapport or trust with your clients. And I think it's the same with muscle testing, that I have kind of a scale of different explanations that I use, ranging from the really simple, all right, go and match my pressure, all the way up to, all right, break out the laser pointer and the chart and the easel and explain the intricacies of motor control, depending on what they want to know. But I generally start with something really simple. But the techniques, the verbiage I'm going to give you now would be if that didn't work. Okay. And I needed to be a little more specific to help this person figure out the test. So for one, it's important in my mind, even though we often use the words meet my pressure, I don't want them meeting my pressure. I want to meet theirs. Okay. I want them to initiate the test. They call it a type 3 muscle test, where the client initiates the test submaximally and you meet their pressure submaximally, and then you ramp up together. When we say the words meet my pressure, it kind of suggests what's called a type 1 test, where you initiate the test and then it's up to the client to be able to respond and react and then maintain some sort of stability. And most people are not going to be able to do that for most tests. And you're going to get a lot of false positives on the test. You're going to seeing people failing a lot of tests that they otherwise wouldn't. So even though, to my mind, it's kosher to use the words meet my pressure, I use that only to create the impression in the client's mind that they're there to match me, not to beat me. That it's not a competition, that I'm actually trying to gather information, and the harder you work, the less information I get. So I'm figuring out what needs to be done. A perfect test for both of us is where we have an absolute tie with minimal effort on your part.
Okay.
That's a perfect outcome. But if you're having to hold your breath and grit your teeth and dig your heels in and twist this and torque that, every ounce of that you're doing is robbing me of that useful information. So usually explaining what I'm actually trying to achieve in doing a muscle test is really helpful and kind of bulletproofs against your hard testers, the people who want to win and give you every ounce. If I explain that it has nothing to do with who wins, that's not what gives me the information. It's the quality of the test. It's the quality of how well you test when not doing those things that actually gives me the information. So all the work they're doing to try to, appease their ego, is actually just getting in the way of the session. So usually one sentence on that is usually all it takes to get people to not do that.
Okay.
So I might say meet my pressure, but I actually get them to initiate. So one of the things I'll commonly do, and I talk about this in the palpation class a bit, is say I'm just testing a straight arm push down, test arm, client arm. So I'll say meet my pressure, and then I'll give them a little cue. I'll give them a little tap that tells them when to start. So they're actually starting, but with the intent of then meeting my pressure. So I don't want them to think, wait for me to put pressure and then match it. So I cue, go ahead, meet my pressure. So I add the extra verbiage and a physical cue. That gives them the timing. And then I only want them to give me what I'm giving them. And then we ramp up together till either they fail the test or I've given them enough resistance over enough time that I can safely call it a pass.
Okay.
Whichever happens first. Sometimes if I'm doing a kind of a confusing test, like maybe it's a complicated motion that's a little unfamiliar to them, I'm a big fan of basically giving them a preview of the test. So if you're going to be doing an upper pec test, maybe that's not a motion that they think of very often. I'll take their arm and say, all right, so we're going to do this motion right there, kind of towards your nose. So I give them a kinesthetic rehearsal, a dry run of the motion, so they know which way the resistance is going to come from, so that they'll be ready to respond faster. So they're not pushing this way while I'm resisting this way.
Right.
And we end up kind of getting an arcing motion on the test and getting a false fail, where basically they failed because they thought they were doing this test and they were actually doing that test.
Okay.
And that just gives you a bogus reading all across the. So I want to make sure they're using what I'm trying to test. So giving them a dry run through can be really useful. And another thing I'll often do is I'll combine those type 1 and type 2 muscle tests that I was talking about, where I will actually initiate the test for the purpose of cueing them to initiate the test. And I'll explain what I mean. So I could take anybody with any motion that they've never done before, and even an experienced NKT person, I can just make up a test, some nonsense test off the top of my head, give them any vector I want, and say, all right, go and match my pressure. And then I just lightly start pushing so that they can feel the vector of resistance that I'm applying. So they can see which way I'm pushing. So now they know which way to push back. Then once I feel them start pushing back, then I actually start applying my real resistance. So I'm basically using that initial pressure just as a cue for them to know which way I'm coming from, so they know which way to go. Yeah. And then once I feel them find that connection, then I start testing it with more pressure. And you can do that without a person having any clue which direction they should be preparing to go, because they'll feel it happen, and then they just know to go against it, and you'll end up getting a perfect test.
Okay.
That's one of the things I'll talk about, particularly for more complicated tests. Give them a dry run through and give them a little taste of the pressure first, so they know which way you're coming, so they know how to resist you.
Yeah, that's great. Thanks so much. Thomas, I just got a couple more questions for you. You mentioned some books that maybe you used to read earlier that just were entertaining books? And
I've had to thin the herd many times over the years because the shelves on my bookcase were literally doing that.
No way.
I couldn't open the doors anymore.
Oh, wow. Could you share with us what some of those really helpful books were?
Well, different books have been helpful at different times. Early on, I found Trail Guide to the Human Body really helpful.
Mm-hmm.
Lots of different anatomy books I found really helpful. I found Anatomy Trains really helpful just to give me kind of that concept of the myofascial interconnectivity throughout the body there. Lots of orthopedic exam books. I found those really helpful, or actually just orthopedic books in general. I have one, I think it's like Complete Orthopedic Exam by McGee. I found a huge blue book that doubles as a weapon. I think this thing probably weighs 15 pounds.
Mm-hmm.
I found that really helpful because even aside from just the orthopedic exam, they go into the mechanics of the joints.
Mm.
So it was really helpful in understanding the mechanics of the joints. There was a book I read by there was Diagnosis and Treatment of Movement Impairment Syndromes by Shirley Sarman. That's kind of one of the Bibles of physical therapy right there. I found that I got a lot of gems out of that. The Kendall and Kendall book,
Mm-hmm.
obviously their muscle testing book, but they go into more than muscle testing there. Found that really helpful. There was one by a couple PTs. I want to say they're a husband and wife team. Last name is Seamus. I wish I could remember the name of the book, but it's kind of a smallish book, blue with green trim. But what I liked was the way that was organized, and it's about orthopedic injuries. And they'll basically, by body part, give you a list of the different orthopedic injuries, the mechanisms behind those injuries, like how they happen, and then basically step-by-step protocols on how to rehab it.
Hmm.
So I found that really useful, not only in learning the different types of orthopedic injuries, like what the differences are between them, but, you know, what does a return to running program look for someone who's post-ACL repair?
Hmm.
You know, so it's nice to not have to piece that together from multiple different locations, just have kind of A through Z in that one book and have it organized that way. I found that really
Mm-hmm.
useful.
Okay.
Geez, I've read so many things. I don't even know where else to begin. But those were ones I read early on that I found really useful.
Okay, great. Yeah. It sounds like you've read so many
stuff
books.
I read nowadays would put most people right to sleep. So
yeah. Sounds like you've read
it's
so many books.
Soporific.
You forget sometimes what they're even called or what they are, but that's great that you've learned so much.
Yeah, well, I mean, a lot of the stuff I learned so long ago,
mm-hmm.
but prior to being in the industry, that it's like I couldn't even organize it properly in my head. So I'll know these things, but don't know why I know them.
Mm-hmm.
Because it's not like I learned them in school or at a course or something. You know, it was a big fat book I read while I was on cardio, and I can't even remember the name of it.
Yeah.
But I'm just pulling up these facts and stats and, you know, anatomical concepts, and I'm like, I have no idea where I learned that, but I know I read it somewhere.
Yeah.
Now, nowadays I read something and I remember where I got it from. I have kind of a mental bookcase to help me organize that. But everything early on in my training days, it's like I retained it all very nicely. It's just kind of disorganized in my head, and I just know it. I just don't know why I know it.
Right. Well, Thomas, could you leave us any last bit of advice, maybe just a word or a motto or something that stuck with you for all these years that really keeps you on the right track in your work that you do?
Trust what you feel and what you see more than how you test. There's, as I talk about in the muscle testing class, there's a lot of things that can throw off the outcome of a muscle test. There aren't nearly as many things that can mislead your hands. You know, if you palpate something, it's real. Your hands will never lie to you. A muscle test can lie to you very easily. And, you know, we go into kind of protocols to make it as accurate as possible, but also how to interpret things that don't quite add up. So there'll be times where, you know, I can palpate something and I know exactly how it's going to test. I know whether it's going to be strong or weak. I know whether it's going to be facilitated and inhibited. I know whether it's going to be locked or normal, like in its ability to inhibit. I can feel all of those things very easily. I can feel what's related to what, with pretty much 100% accuracy. I'm very good at that. But every now and again, my test is actually wrong, where I have felt something and I was like, I was really sure that was going to be weak, but that tested strong. So either my test was wrong or my palpation was wrong. And to my mind, I will always trust my hands. So to my mind, that muscle should have been weak, yet it didn't test weak because something's wrong. So I'll go and instead of assuming I'm incorrect and just moving on or going to plan B, I'll think, okay, there's something going on making this weak muscle test strong. Let me figure it out. And then invariably I'll find a place to TL that makes it then test exactly how I thought it would all along. Because I found something that was creating some distortion and creating kind of a ripple effect outward and causing things to test differently as a result. There are a lot of things that can cause muscles to test kind of erratically beyond just being facilitated and inhibited. And the number one way I usually spot those is when what I felt and what I tested ended up not matching. Or I'll have times where something feels strong as a rock when I touch it, but when I test it, it's weak. And I'll be like, nope, I don't believe it.
Yeah.
Sure enough, I find, oh, well, if I release this, now it actually tests weak. So it was fake strong. I shouldn't have trusted it. So I've learned to trust my hands, to trust my eyes way more than I trust the muscle test.
Okay.
For me, the muscle test is part of the information gathering process. And for me, the most useful information isn't if something is strong or weak. It's how it feels when you test it and how that compares to the other information you gathered. How does it feel compared to how it palpated? How does that test compare to how that person moved? And getting all those different angles and comparing and contrasting them against each other to get the big picture of what's really happening. So you're not just weighting any one aspect of your assessment so heavily that it blinds you to your other findings.
Okay, yeah. Well, Thomas, this has really been great. It's been a pleasure talking to you, and just thank you so much for wanting to share all your experiences and all the information that you have. It's really been an honor to hear from all the things you got to share. Thank you.
My pleasure. Thanks for having me.